Guys, we'll get started. Welcome to Alabama EMS Challenge. We are live in Tuscaloosa at the Fire College. There's another college here too. They're saying roll something? What is that? Okay, there you go. All right, just making sure I was in the right place. Yeah, I got a few smiles and a few flips. I don't know what's going on. But we're at Tuscaloosa today at the Alabama Fire College. We've got our lectures till 11, myself and then Dr. Brown. At noon 30, we're doing skills lab. So we're going to do advanced surgical airway. We have other airway techniques. We're going to have megacode and do pit crew CPR. So if you're in the area, come out. It's free Con Ed. I really appreciate the Fire College sponsoring us and bringing us out this way. For those of you who have not been involved with EMS Challenge before, this was started back 10 years ago or so to bring physician-led Con Ed to the regions. Here, we've grown to where we have a couple of UAB faculty members. We have 2 fellows, and we have senior residents that come out and do field care in the greater Birmingham area and do a lot of education. So for your certificate today, you can use the link that is on the chat feature. For those of y'all in classroom, there's a QR code you could scan. If that doesn't work well for you, you can always send us an email at alabamaemschallenge@gmail.com. Do that by this afternoon and we'll get your Con Ed credit for you. Things that we have coming up. Next week is the State EMS Conference in Orange Beach. You should go. It should be very interesting. We have over 240 signed up for that already, so it's going to be a big crowd. There's a good pre-con. We'll have a booth. We'll be doing surgical airway skills at our booth throughout the week as well. Several of our fellows and docs are lecturing. The following week, I think it's the 12th. Is that right, Chief? 12th? Alabama EMS Challenge. We at the Alabama Association of Rescue Squads doing a EMT and advanced EMT training for EMS Challenge. December 8th, we're back at Brims with the Skills Lab. January 16th, we have Dr. Kurt coming back out with us. He's a UAB EMS researcher who actually can speak human, not just research language, so he's a good guy and give us some good information. Questions from the back, anyone? Questions? No? Good. All right. Sweet. So first thing I want to kind of talk about is some airway issues I've been seeing here recently and things we want to think about. With airway management, it's not always eye gels or intubation. Remember, there are some simple maneuvers as well, such as jaw thrust, simple things like that, repositioning the airway, sitting them upright, using a little bit of suction. Oral airways, nasal trumpets still work very well. If you're going to go with the blind insertion device or ET tube though, you got to do it correctly though. So by that, I mean you have to confirm placement. And the way you confirm placement, medical, legally, and realistically is with waveform capnography. So if your EMTs or advanced EMTs are placing eye gels, they got to have a way to get capnography, either waveform or the colorimetric. I prefer the waveform, and definitely if you intubate someone, I get it. There's sometimes you know you're in the right place. You see it pass through the cords. You got great breath sounds. The patient gets better. The stats improve. You still have to document capnography. That is a standard of care. I've seen several cases here in the past few months where there have been esophageal intubations that have not been recognized immediately. Remember, esophageal intubations, everyone that you intubate the esophagus on and don't recognize it, that person dies, 100%. So you got to confirm placement. Capnography is the gold standard. You've got to do that, folks. There are web pages out there that focus on just looking for medical legal reasons to go after providers, whether it be healthcare in the hospital or pre-hospital for esophageal intubations. With video scopes, waveform capnography technology we have, I get it. We'll miss the tube sometimes, intubate the esophagus. It happens to all of us, but you got to recognize it on that first or second bag and take it out. You cannot intubate the esophagus. I can't stress that enough. But these things, the colorimetric is a great way to start off. Get good color change, then place them on your waveform capnography. If you're a ALS non-transport, don't have the funds, or if you're a BLS agency using eye gels and all you can get is this, that's fine. I still recommend the waveform, but you got to have one or the other, if not both. It's a pretty bad day if you intubate the esophagus or you got an eye gel that's not working. So, all right, enough on that for now. So we're going to talk about 12 leads today. So one of the big things that I wanted to push years ago was 12 lead interpretation for EMS providers. When paramedicines first started out, the goal was to recognize rhythms, right? So junctional, Afib, asystole, Vtag, Vfib, and treat those things. We really had no way to manage STEMIs at that point in the game. Things are a lot different now. We have ways to manage STEMIs with thrombolytics, with cathabs, and so we got to be able to look at 12 leads and interpret those as medics. The machines do not do a good job. So 12 leads are pretty important. I look at this as kind of simple as a screening tool. And I look at the ventricular rate and I say, is it too fast? Is it too slow? Or is it okay-ish? I like what American Heart does with the too fast, making it out wide or narrow, regular, irregular. With the too slow, I think about three things: drugs, electrolytes, or ischemia. Obviously, other things can cause somebody to be bradycardic. Those things you pick up in your primary exam. You know, the 6-month-old that is blue, not breathing, with a heart rate of 40. What's the problem? They're hypoxic, right? And you pick that up on your exam, okay? The guy shot in the belly, whose heart rate's 140, en route to the hospital, he goes 120, 110, 90, 70. He's bleeding out. You pick that up on your primary exam. Three things you can't pick up are potential drugs like calcium channel blocker, beta blockers, electrolytes like hyperkalemia and ischemia. And then the more scary things on the 12 leads are things: is it okay or not okay? Is there a STEMI and not a STEMI? What's the QT interval? Are the issues there? Things you got to be able to determine is the rate, and you can't just use the monitor. If you print this thing off, the machine does a fair job is reading numbers, but not super great. So I recommend that you have some way to calculate. I use the box method. So I go QRS to QRS, first box 300, then 150, 100. At that point, my mind starts thinking about going fishing or eating dinner. I don't care. If I get 6 or 7 blocks down the road, I know I'm way too slow, but have a way to calculate that for you. Intervals are very important. The PR interval, we all under medic school about first-degree heart blocks. First-degree heart blocks are not concerning. They don't scare us. But a prolonged PR interval in the setting of somebody who could have hyperkalemia is very concerning. It's one of the first signs you'll see, not just a peaked T wave. QRS interval is important. Determine if it's a left bundle or right bundle or Vtag. And then the QT interval should be half the R to R interval. And a prolonged QT puts people up to having a dysrhythmia called torsades, which is pretty cool because if they have torsades and they fall, hit the ground, and kind of shake themselves out of it, we call it syncope. If they have torsades, fall, hit the ground, and quit breathing, we call it cardiac arrest, right? So it can be concerning. It's a tough in-person crowd today. I might have to start telling inappropriate jokes or something. I don't know what to do. All right, so EKGs, I'll say this rate is okay-ish. If I do my box method, I got 300, 150, 100, don't care. So it's in the 70s, okay? At this point, then I'm gonna go and I'm gonna look for injury patterns. I'm looking for a STEMI, right? So I gotta have an ST elevation and 2 leads on the lateral lead. So there's 1, AVL, and 5 and 6. So I'm looking for ST elevation, which would be a STEMI, or depression, which is concerning for ischemia, which makes me uncomfortable, but it's not a STEMI, right? Next place I look is 2, 3, and AVF. Same thing for elevation and depression. I look V1 through V4, 1 and 2 here, or I forgot I can't draw, can I, Chief? Yeah. So these are our septal leads, and these are our anterior. So elevation and leads are concerning for a front part. And then if you think about old school posterior, what we used to talk about, you take the EKG, you flip it over, you look for elevation on the backside. Don't do that much anymore. The paper's a little bit different, but ST depression, T wave inversion, V2, 3, and 4 is very concerning for posterior infarct. That is a STEMI equivalent. I know a lot of people talk about at that point, if you see this, you take the EKG leads off, you do a posterior EKG. I say that's bunk. This is enough data to get them into the STEMI system and have them seen by a cardiologist, okay? We should not be wasting our time doing posterior EKGs in the field. We should recognize there is a STEMI. We should initiate treatment and move them toward definitive care. If it's not a STEMI, we can figure that out later. But that is a STEMI equivalent. It goes in the system and needs to see a cardiologist. And the last thing I look at is lead AVR. So for years, we said AVR was only good to see if the leads were on right. So if you're up in 1, you should be down in AVR, your QRS complex. In reality, if you get ST elevation and lead AVR at all and get depression anywhere else in an injury pattern, that's concerning for a left main occlusion. That could be a STEMI as well. That was discussed pretty heavy in 2013 with AHA, and they still talk about that. After I look for injury patterns, the next thing I'm going to look for my interval. So I'm going to go to lead 2, and I'm going to look for my PR interval. All right. I'm going to look for my QRS. I'm looking at my QT. My QT should be half this R to R interval. So that QT interval looks good. If my QRS is wide, then I'm going to go over here to lead V1. And I'm going to look at this, and this is how to determine is it a left bundle or a right bundle. Okay. And before I get done, I'm going to put this thing back down. I go one more time. Back looking at leads 1, AVL and lateral, 2, 3 and AVF, V1 through V4, and the AVR. Because there's some days I've been up way too long and I'm tired. I don't want to miss a STEMI. I don't want to feel bad about it. So I look at these the same way all the time. Now, people talk about vectors, learning vectors with 12 leads. Yeah, I learned those a long time ago, just like you. And yeah, I don't remember them at 2 in the morning when I'm really tired. So I got a memory pattern that I use, and I keep this, and I do it the same way every time. If you're not looking at 12 leads every day on shift, you got to look at them somehow. So there's a website, Wave Maven works pretty good. Life in the fast lane is reasonable, but it's like anything else. You know, if you start one IV every 6 months, you're going to suck at doing IVs, right? If you look at 112 lead every 6 months, you're going to miss something on that patient in front of you. Somebody's going to have a bad outcome, and you're going to feel bad, and they're not going to feel too good either. So I've gone through my injury patterns. I look here, my intervals are fine. I look here if my QRS is wide. If it's not wide, one more time for injury patterns, and I put it down. So on this one, when I get to looking at lead 2 to look for my intervals, my PR interval looks okay. My QRS is wide. So I'm going to go over here to V1, all right? And I'm going to determine is this a left bundle or a right bundle, all right? And how do you determine if it's a left bundle or a right bundle? Most people say you look right here, all right? And I say you can't do that, right? Don't trust the machine, right? It's like the government. It thinks it knows what it's doing, but it really doesn't, all right? So I look at V1. If it's pointing down, that's a left bundle, all right? This is a screen tool. We don't have to get super fancy about this. We're trying to keep this to recognize injury patterns and the most amount of people we can. So wide QRS, I go to V1. If V1 points down, like you're turning left, it's a left bundle branch block, okay? So again, we're not going to talk vectors. Every 6 months to a year, I go back and relearn that to make sure I'm not confused, but I cannot use that skill at 2 in the morning, guys. So left bundles, there's something in the electrical activity of the left side of the heart that's jacked up. It's usually from ischemia. Sometimes the heart gets enlarged and it stretches these fibers and it makes the pathway get slow. So it slows that conduction and you get a wide QRS complex, all right? So you got to have a QRS greater than 120, so a wide QRS, all right? Discord is good. There's usually a Q in V1 and no Q in 1. All right, so I got a wide QRS. I go to V1, it points down. That's a left bundle. I can kind of confirm it if I want to be fancy and look at AVL. There's no Q wave, so it's still a left bundle. I usually just use this rule, right? And that's important because with left bundles, if you look at this, where's one without the heartbeat? That makes it hard. So if you just look at this one, normally, and I look at V1, I got some ST depression there, AVL, 5 and 6. That makes me very concerned for ischemia. 2, 3, and AVF, wide complex, but not ischemic. But I look V1 through V4, and I got some elevation here, there, and there. So you can think there's a big ischemic event going on. That's why it used to be all left bundles we talked to cardiologists about, but not all left bundles are actually an acute MI. We got something now called Scarbosa's criteria that we can use. So basically it's concordant ST elevation, QRS the same direction as the T wave, and ST elevation is concerning for a STEMI. The posterior stuff that we talked about is still relative. If it's concordant, QRS the same direction as a T wave. But when you got discordance, when you got the QRS going the opposite way of the T wave, you actually got some latitude. You got a full 5 millimeters. You got a big box right there. That makes it reassuring. Okay. So this one, I would look at it. We talked about 1 AVL and lateral, concerning for ischemia, but not a STEMI. 2, 3 and AVF, not bad. But V1 through V4, I would say that's elevated. That's concerning for a big STEMI there, right? When I go back over here, I look at AVR, not elevated. I look at intervals. PR is fine. QRS is wide. So I go look here. I see it's a left bundle. I apply Scarbosa, and I realize that this is discord, so not a STEMI. Sweet. Anybody still awake? Yes, you in the back. Wipe the drool off your face, please. Thank you, sir. Good, good.
Hey, Doc.
Yes, sir.
Hey, we do have a comment from online. Somebody writes, we should probably stop separating V1 through V4. They're all anterior if you have elevation in V2 and V3. It's an interesting point because I noticed that you always kind of lump V1 through V4 together.
I do.
Some of the textbooks separate V1, V2 as septal, and V3 and V4 is anterior.
Yeah.
Thoughts on that? And does it
yeah,
make a
so I mean,
difference?
technically these are septal, V1 and V2, and these are anterior. But in reality, I think this is one dysfunctional family, right? So if I had this, all right, if that was not a left bundle, that'd be a septal infarct acute versus anterior, but tomato. I use, V2, 3, and 4 for my posterior leads. In reality, it's 3 and 4, but it's all kind of relative.
So does that affect any way we look at contiguous leads for elevation? I think that's kind of where the confusion.
No, so if I had elevation in V1 and V3, I would still call it a STEMI. Yeah. Because you also got to remember, when you place these things, how close those leads are together. They're pretty close, right? So I would call that a STEMI, yeah. So I would, for interpretation purposes, I would lump V1 through 4 together. So here's another one. So rate, too fast, too slow, or okay. I said the rate's okay. I use 50 to 140. 50 to 150 is an okay rate. So my rate's reasonable by the machine. I got 300, 150, 100. So it's around 100. I start looking at injury patterns. I'm looking at 1, AVL and lateral. Then I look inferior, and now I see some T-wave inversion, concerning for ischemia, not a STEMI, but concerning there's some heart issues going on, right? Then I'm looking V1 through V4, and this makes me very uncomfortable, right? So by definition, I'm gonna call this a posterior MI, right? I got ST depression, T-wave inversion. So first glance, I'm thinking, okay, this dude's having a big posterior MI, but I do the same interpretation every time. So I've done V1 through V4. I'm very concerned about a posterior MI because of this. All right. Then I go to AVR. 1 and AVR are opposite, so that's good. AVR is not up, so that's fine. Then I'm gonna go look right here. Periinterval's good. My QRS is wide, right? So I look there and it says it's what, 150? So wide QRS. So I'm gonna go to V1, and now my QRS points up. So instead of a left bundle branch block, this is a right bundle branch block. Okay. And so with the right bundle, you're going to see that this T-wave inversion, ST depression, that's normal. So really not a STEMI. It's just a complete right bundle branch block. Okay. So this is a little bit more advanced than the regular stuff that we do. I know that. If you have to err on the side of caution and you got a guy that's diaphoretic, looks like dirt, having chest pain, and you have this EKG, and you call med control and put this into the STEMI system for a STEMI, nobody's going to fault you because it's still concerning because the patient is sick, not because of the EKG, right? But that's why it's important to understand left and right bundle branch blocks because it kind of changes things. I forgot I could draw on this board, so I drew them earlier. Use different colors too. Looks good in my mind. So what causes a right bundle branch block? So lots of things, right? But the main thing is right heart strain. So anybody who has pulmonary hypertension, COPD, chronic heart failure, you'll see that right side of the heart get big, and it slows conduction, so that QRS gets wide. And the defining characteristics of that right-sided is the big R wave in V1 with a wide QRS. This is a cheat sheet that I like. A lot of times I'll take these and I'll have a teaching case with a 12 leads shows a STEMI, and you can overlay this and it kind of shows you where it is. But, this is the left main coming down, all right? If you think about the right and left coronary come off the aorta, and that's right where AVR kind of points. So elevation here is a very proximal lesion. So very concerning for a bad outcome. A lot of times these folks will have a big STEMI there and they die before we get there because the majority of their heart's wiped out. The lateral is a circumflex artery. And then you got the right, which is the inferior. And then I like this picture because it tells us why we another reason why we gotta look at 12 leads, right? We cannot trust the machines. Machines don't do a good job at interpreting things. They also can't apply what's going on with the patient. So what's wrong with this monitor picture here? Anybody? Bueller. Yeah, so what the heck is that? That doesn't even make sense, right? You can't have a 79/80, right? Right? So machines make mistakes, right? So we got to be able to interpret 12 leads. The other thing, when I looked at the BREMS data for the last quarter, 16% of the STEMIs that came into our system at BREMS now were medic entry. So the machine did not read STEMI on the 12 lead. The medic recognized it, called in, it was confirmed by the ER doc, and that patient went to the cath lab. So that's 16%. That's a lot of freaking patients that we would have missed had the medics not been able to read a 12 lead and interpret that. So very important stuff. This is a video that the patient's in the cath lab, the catheter's in, they're putting the balloon up, and you can see they got ST elevation when the balloon's down, but when they go back and inflate the balloon and get circulation, ST elevation changes. So it's pretty cool. So, and they're right there, they're trying to get that clot out, inflating the balloon, crushing it out, they're giving blood thinners, they put the stent in. Interesting stuff. Sweet. Semi-inappropriate humor, but not super funny because nobody's moving. Thank you very much. All right, so first case. This is a 53-year-old weakness, short of breath. You get on scene, they have a palpable pulse, but it's fast, breathing a little bit fast, saturated 96, blood pressure's fine. Always get a D-stick if you're starting a line on somebody, gives you a lot of data. If it reads low, you can fix it with D50, right? If it reads high, you know what the problem is. Anything between low and high is fluff, right? So that's the 12 lead. Too fast, too slow, or okay? Thank you, the guy in the back. Very good. I would say it's too fast too. Yeah. Machine says it's 200, right? If I do box method, I'm going to do 150, 300, 150, right? So it's pretty fast, between 175 and, 200, pretty fast. All right. So next question American Heart says after that is it wide or narrow or regular or irregular, right? So is that wide or narrow complex QRS? Narrow. Is it regular or irregular? All right, who votes regular? Let's see some hands so I know somebody's alive, please. Who says regular? I got 2 regulars. Who says irregular? Who says I'm not going to answer, you can't make me? You in the front. Very good. Thank you, sir. I like this guy. Roll Tide. Yeah, very good. Yeah, all right. Yeah, so how can you determine regularity? What do? Oh, I can't count, dude. I'm too tired. I've had too much Monster. You can measure them out. What's the easier way to determine if it's regular or irregular? Feel the pulse, touch them, you know what I'm saying? Touch their body, right? Reach down, touch the groin, touch the radius. If they're unresponsive, touch the groin, all right? Wait, never mind. So that would determine if it's regular or irregular, right? So rates greater than 180 is tough to figure out if it's regular or irregular sometimes on the monitor. Especially with me, I can put my glasses on, I squint, I take 5 minutes. When I can fix it all in a matter of seconds by touching the patient, right? So this one's pretty irregular. It's Afib. It's probably the most common dysrhythmia you guys will ever see. Oh. Can we go back one first? Yeah, man. Yes, sir.
I've seen regular on the monitor and irregular when I touch them.
Yeah.
So the EKG is regular, but the pulse is irregular.
Right. So they're an Afib.
Right. I get that. But,
yes.
But you were asking about the EKG.
Oh, okay. Yeah, no. I'm just messing with you.
Okay. I'm just trying to make sure.
Yes, sir. You're correct. So my point to that is the EKG sometimes is hard to figure out. On the paper, yes, you would measure it out. I can't do that. I'm a cheater. I'm gonna look at it and go, that's too fast. That's narrow complex. I'm gonna reach down and touch the pulse, and I'm gonna say, is it Afib or not Afib? Is the way I'm gonna do that. But Afib is probably the most common. Folks that smoke, have pulmonary hypertension, we see them Afib. As we get more mature in life, we'll all end up with Afib, all right? So the goal is to get Afib at some point. You don't want to die early, right? It causes two problems: decreased cardiac output, and you get a risk for clots. So anybody ever seen a patient on a blood thinner? Yeah, so somebody's rich off of that. Everybody that has AFib is on blood thinners these days, right? But big issues with AFib is decrease in preload and the risk of thrombus formation. So what's going on? Normally you get SA node, fires, goes to AV node, you get contraction. With AFib, what's happening, for some reason, this atrium is stretched and all these fibers not working, but because the heart is able to self-propagate and make its own impulse, as these start breaking apart, you get different parts of the atrium that fire, so you get irregularity there. Long-term issues, hypertension, acutely thyroid issues can cause it. There's no way to diagnose that in the field, and actually we diagnose that in the hospital because on day 2 of the hospital stay, the thyroid study comes back and they go, oh, you're hyperthyroid. Great, nice to know now, right? Acute alcohol, something called holiday heart. So folks that live near college towns will see young kids coming in and AFib RVR just because of the toxins from alcohol. Obviously, Coke, crack, speed. COPD is very common. Pulmonary embolism and acute PE will cause somebody to get tachycardic and go into AFib or aflutter. There should always be a differential. Electrolyte issues, but then heart failure is the big one too. So you got to determine with AFib, is the rate the problem or is the rate the response? So AFib with a fast rate of 200 is the same thing as sinus tach for somebody who has sinus rhythm. So if I go out and jog a mile and I have AFib, my heart rate is going to go up to 150, 160 because I'm running and I'm in AFib RVR. I don't need medicines to fix that. I need to stop what I'm doing, chillax a little bit, maybe get some hydration, and I'll be fine. But there are some folks who go into AFib and that rate gets too fast and causes a decrease in cardiac output. So you got to figure out, is the rate the problem or not the problem? And most of the time, the rate is a response. The way we treat this in the hospital is we say symptom onset. If it's less than 48 hours or greater than 48 hours. So less than 48 hours, we can actually control the rhythm because there's less risk of thrombus formation. So we can give them drugs like procainamide or amio. There's a drug out there called Corbert that would take them out of AFib. It's kind of like a chemical cardioversion. All right. The only risk for that is that potentially they could have a clot that we could throw up because they go back into sinus rhythm. A lot of times we do rate control with beta blockers, or then calcium channel blocker. DILT is one that you guys can use in the field these days. If it's greater than 48 hours, these guys, we don't want to cardiovert them immediately. What we want to do is make sure they don't have a blood clot. We usually give them blood thinners, get an echo, look at their heart, make sure they're anticoagulated, and then try to shock them out. So it gets kind of confusing. A lot of the literature is changing here lately. In reality, what we really do is most people have AFib with a fast rate. We look for the problem. If they're dehydrated, if they're septic, we fix the underlying problem. That fixes the AFib RVR. And if not, we control the rate. And we let them see a cardiologist, and they go in and they kind of burn out those weird areas in the atria and fix the AFib that way. Because cardioversion usually doesn't last a long time for lots of people. Unstable AFib is probably one of the scariest rhythms you take care of. So if you got an old guy with heart failure who's an AFib RVR in the 190s, 200, and he's hypotensive, those guys are super scary to control because any of these medicines is going to drop their blood pressure, right? And these things are going to take them out of AFib. And if they in AFib with a fast rate and a bad heart, remember that cardiac output is heart rate times stroke volume. They could be having that fast heart rate because their heart isn't working well. And if you drop that heart rate down with medicines or electricity, you can drop their blood pressure even more. So the point of that is, if you give somebody cardioversion in the field for AFib RVR and they become worse, blood pressure drops, you got two options. What's the reversal drug for a calcium channel blocker? Anybody know? Y'all got it? It's in the yellow box. Calcium, yeah. So if the pressure drops, they get worse post-calcium, the diltiazem, give them an amp of calcium. If that doesn't work, you think about hanging something like dobutamine, something that gives the heart more squeeze. So these are the scary ones to manage because you're not really sure if the rate's the problem or the response. And if you pick it wrong, you could actually kill somebody. So this is a young female with palpitations. She was doing Red Bull. I'm more of a monster guy myself, but Red Bull's okay. Too fast, too slow, we're okay. too fast. Yeah. So we say, is it regular or, excuse me, narrow or wide complex QRS? Pretty narrow. Yeah. So the rate is like thumping along 300, 150. So still 175 to 200-ish, right? Narrow complex, regular or irregular on the paper. Thank you, sir. Yeah. And on the patient, touch the patient, is regular as well. Yeah. So what is this? Yeah, SVT. Yeah. The other telltale sign, if you have elevation and lead AVR in the setting of a narrow complex QRS, it's SVT. A kind of telltale sign. So what are we gonna do for this chick? What do you do for her? Shotgun the rest of your Red Bull? Take it away first. You drink it. Yeah. Yeah. So vagal maneuvers, what do you make them do? Bear down. Yeah. Sometimes they crap on your stretcher. That's kind of uncomfortable for everybody. Yeah, you can do that. Yeah. I say blow on your thumb. They look at you like an idiot, but like, what? So blow on your thumb, blow on a syringe. There's some videos out there of docs having them. They sit, they blow on a syringe, they throw them back and raise their feet up. Most of the patients I take care of aren't healthy enough or small enough for me to help do that. I'm not going to take a 300-pound person and make them do all that. They're going to fall off the bed. Then you got to transport them anyway. But vagal maneuvers work great. If that doesn't work, what's your drug of choice? Adenosine, right? So adenocard is pretty good. Limited risk. Adenosine basically blocks this node for a couple of seconds. And in theory, what happens is this re-entry circuit there gets broken. And so everything goes back to normal and it stops that. Works great. So you can do 6 by our protocols. I usually do 12, seems to work better. I always tell a patient they're going to feel like dirt for a second. All right, everybody freaks out. Usually you see a sinus pause or asystole for a few seconds. The patient should look like dirt, feel bad, usually moan, and they call you mama names. All right, and they should get better. All right. So this is a SVT. Gave a little bit of adenosine. They start moaning. Reach over, grab your hand, and then we get this. Works pretty good. If you do not see this, odds are the medicine did not kick in. You did not give it well. It went up the IV line. It wasn't fast enough. It was too low of a dose. I was watching the ER a couple of weeks ago. They were pushing the adenosine. I saw bubbles go in the IV bag. What does that tell you? Ain't going to work, right? Because the IV fluid, the medicine went the wrong direction. So I said, yeah, go ahead and drop 12 more. It's okay. But adenosine works pretty good. How about this one? So I was working down in South Alabama, and the triage tech brought me an EKG that looked like this and said, can you sign it? And that was my expression, right? It's like, what's going on? So what is this? Too fast, too slow, or okay? Looks good. Move on. Next patient. All right. Very good. Yeah. Yeah. No, that's a Y complex tachy, right? So our rate is 300. Our rate's greater than 200. It's wide. All right. My hand is on the pulse, not to see if it's regular or irregular, but to see what? If it's there, right? So American Heart talks about stability. Stability is relative. There's no way they're not going to have that rhythm and complain of chest pain or shortness of breath or diaphoresis. Stability is, are they alive or not alive? Are they self-sedated, right? So if dude's talking to me, yeah, I don't feel good, got a good blood pressure, that's somebody I'm going to sedate and think about doing some cardioversion. If the dude is, saying Earl or War Eagle or something confusing like that, then he's probably going to get shocked right off the bat, right? So you can do amio 150 over 10 minutes. In reality, who actually gives it over 10 minutes? Raise your hand if you do. Yeah, that's what I thought. You can also do lidocaine. Lidocaine is a pretty reasonable drug. There in the 2000s, everybody went to amio for everything. Nothing wrong with that, but amio or lidocaine. This person can get IV access. He can get pads put on him because odds are they're going to decompensate. What he really needs is a little bit of electricity. So synchronized cardioversion, the candle should be on the machine, pads on, leads on. If he is alert and talkative and needs sedation, call med control, but watch the airway. If he's self-sedated, service is going to hurt. Sorry about that. Synchronized cardiovert and let it go. Electricity is how you fix this. We just happen to have on the monitor in and out of Vtag. We actually caught it. All right, this one, too fast, too slow, or okay-ish. Too slow, right? So I'm gonna start doing my 300, 150, 100, 75, can't remember. and it's just way too far, right? So way too slow, all right? So the question now is the patient talkative? Are they symptomatic with this? Odds are they are, right? Three things I think about are drugs, electrolytes, and ischemia. Everything else we should pick up in our primary exam. So that patient with that rhythm is going to be hands-on. Somebody's putting the pads on. We're getting IV access. I'm getting an AccuCheck. I'm starting a fluid bolus. I'm probably raising the head up a little bit for airway secretion control, and I'm putting some O2 on for pre-oxygenation, right? Before we go into cardiac arrest. That's a concerning rhythm, way too slow. So STEMIs, hyperkalemia, and drugs are the big issues for these folks. So how do we treat them after that? I got fluids, the upright, got O2. What drugs can we give folks for bradycardia? Atropine, yeah. So atropine's great. So a lot of people don't like atropine because they say, well, if it's third-degree heart block, it's not going to help. But my argument is it's very easy to find in the darkness in your drug bag at 2 in the morning. There's limited risk. You give somebody one atropine. If you get lucky and it works, you high-five your partner and you're done. Transport, 12 lead, move to the hospital. If it doesn't work, you keep on moving downstream to give other medications. What else can we give them? Anybody using push-dose epi? Yes, no, no comment. I get a couple of yeses. So epi's good, all right? I like calcium as well. If you think about the three big reasons of bradycardia, one is hyperkalemia, right? And hyperkalemia, calcium stabilizes that cell membrane, works pretty good. The other good thing about calcium is it increases. If you give calcium, it increases the calcium inside the cardiac cell, increases heart rate naturally. So limited risk, potential benefit. I think calcium's a great drug. All right. Dopamine. Anybody still carry dopamine? Yeah, so I like dopamine. Some folks don't. Dopamine's great for a symptomatic bradycardia. Heart rate is slow, blood pressure is low. It fixes both. It is a titratable drug. So what I say is you spike the bag, you prime it, you hook it up to the patient, and you open it up. You're watching the patient. You get your second IV. You get more of a history. All right. You get your pads put on the patient. You look up in a minute later. If the heart rate is now 80 and the blood pressure is great, you dial this back and titrate it to 10 mics per kilo per minute. You call it a day. If after about a minute or so, the heart rate is still low, they still look like dirt, you dial this back, titrate it to 10 mics per kilo per minute, and you move on down the road. Think about push dose epi. And then the other thing you can think about doing is you can think about doing pacing as well. Hopefully pacing will go to category A soon. I know it's cat B right now. So if I was on scene with a patient that was bradycardic and altered, I'd have my EMT call, hey doc, got a 54-year-old patient, bradycardic, hypotensive, unresponsive to atropine and dopamine. I'm gonna give calcium and pace them. Thanks. Click. Tell them what you want, what you really, really want, right? Just like the song, and get your orders. So supportive care is ABCs always. Atropine, calcium, dopamine, microdose epi, pace them. If I'm pacing somebody, the odds are they're going to get intubated as well. People always ask about blocks, you know, first-degree heart block, second-degree, third-degree. First degrees don't matter. If I see a first-degree heart block in bradycardia, I'm thinking hyper-K. It's the first thing I'm thinking, right? First-degree heart blocks don't cause anything. Second and third degree or higher grade. Sometimes the people don't understand what the textbooks say, and they go in and out of that. They're not always in a third degree. They go back and forth. So that's why I say atropine's reasonable. And I say in a symptomatic patient, who cares what the block is? Treat the patient. If we get to pacing, they're going to go to the cath app and get a pacemaker put in anyway. All right. I'm not saying don't learn about these blocks. What I'm saying is don't spend 20 minutes arguing with your partner over is it a second degree type 2 versus a third degree when the patient has a heart rate of 30, the blood pressure is 70. Thank you for almost smiling. Good. Inappropriate humor is an old slide, but it's a goodie, as they say. Roll Tide.
Hey, Doc.
Yes, sir.
So I got a question. Is calcium being considered as an inotrope in incoming critical care EMS guidelines? For example, patients on multiple pressors that are refractory.
Yeah, usually folks on multiple pressors refractory, I'm thinking something else. Are they steroid dependent, need some hydrocortisone, or something else going on? So routinely, no. But in cardiac arrest or bradycardia, somebody that's peri-arrest, I think calcium's reasonable to do. Thoughts from the other docs in the room? No, no comments. All right, I got a smile though, good. All right. So this was a 46-year-old male passed out at Walmart. He's dyspneic, recently got put on some blood pressure medicine because his wife made him go to the doctor, got put back on his albuterol. He has a big swollen leg. This is the EKG. Too fast, too slow, or okay. So the rate's okay-ish. 300, 150, 70, so, in the hundreds. I look injury patterns. Inverted, but not a STEMI. 2-3 in AVF. Again, inverted, but not a STEMI. V1 through V4, that makes me uncomfortable, right? I look at AVR. I'm a little bit up in AVR. I go look at my intervals here. PR is okay. QRS is a little bit wide. So I go over this way. My QRS is up. That's my T wave. So what is this? Looks like a right bundle to me as well. So a little bit fast with the right bundle. So I got evidence of right heart strain with somebody who's hypoxic, right, and syncopized. So what is his diagnosis? Is it proven otherwise? Yeah, I would say PE. Yeah, PE. Yes, a new right heart strain. Don't know if he has an old EKG or not, but I would think PE. Syncope, tachycardia, hypotension tonight. So think PE. Well, this one, too fast, too slow, or okay. You gotta say you're an idiot, doctor. Why would you even ask that question, right? Yeah. So my first question, if I saw this EKG, somebody hand this to me, what's my first question? Do they have a pulse? That looks like a PEA, right? Like a post-cardiac arrest. I gave too much epi and that's all I got left, right? So dude's talking to you with this. What is this? What's the cause of this rhythm? Anybody know? No. So it's too slow. So it's a slow, wide rhythm. Wide QRS. Really don't see the PR intervals, right? 3 things cause this. Drugs, electrolytes, or ischemia. So he's either having a big freaking heart attack, but I argue if he's having a heart attack and his EKG looks like that, he's probably dead or dying right in front of you, not talking to you. This is hyperkalemia. This is hyperkalemia gone wild. So textbooks talk about peak T waves. Don't really care about peak T waves. What you see is a wide QRS and a wide PR interval. That should be easily recognized, right? How do we determine somebody is what's the risk factors for hyperkalemia in Alabama? What now? Living in Alabama? Yeah, everybody's got it, right? How many patients have diabetes? How many have hypertension and kidney disease? All of them, right? So Y complex, QRS, bradycardia, hyperkalemia, right? Other things that can give you a hint, if they got a dialysis graft, that's a hint as well, right? Touch the patient. We treat this with calcium. It stabilizes the cell membrane. The 3 S's, stabilize, shift, and excrete, right? So calcium works great. In the hospital, we ship this with insulin and D50, but y'all can use albuterol. Albuterol is a great drug to shift potassium levels back into the cell. The dose is 20 mg, so you give 4 or 5 albuterol NEV treatments, put it in the chamber, hook it up to them, crank it up. If it takes a while to get IV access, no harm, no foul. Albuterol buys you time to take care of this. Works pretty good. The way we do this in the hospital was once we do the albuterol, the calcium, the insulin, we go back, we put a big IV in them, and we get them to dialysis, right? Or the other S, or excretion, we have medicines that cause people to poop a lot. And as they poop, it puts that potassium out of the cells and kind of fixes it. It's a great video, isn't it? Yeah, good. It's almost done. We got to watch it one more time. Should have shown this one first. This is the most movement y'all made all morning, guys. This is great. Good. Very good. All right, so this one, too fast, too slow, or okay? I'd say the rate's okay. So I'm going to look injury patterns. I'll look leads 1, AVL, 5, and 6. Got some T-wave inversion. Looks kind of funky, but it's not a STEMI. 2, 3, and AVF look reasonable. V1 through V4, I don't see any elevation, but I got these things. That's just a biphasic T-wave. Looks uncomfortable. Or makes me uncomfortable, right? But not a STEMI. I look at AVR, 1 and AVR separate. AVR is not elevated. I come back here. PR is good. QRS is good. QT is good. All right, so I'll look at this one more time, make sure it's not a STEMI before I put it down. But what is this? This is actually called Wetland Syndrome. So if you see these biphasic or deep inverted T waves, V1 through V4, it's concerning for Wetlands, which is just kind of a stenosis of that main artery, right? So they'll come in with chest pain and weakness, right? You get an EKG, the EKG looks normal, doesn't have that Wetlands looking thing. When their chest pain goes away, you repeat the EKG, you're gonna see these big biphasic T waves again. right? So that's why in the hospital, before we discharge somebody with chest pain, everything looks great. We'll repeat that EKG to make sure it doesn't change. Your EKG should not change over the course of hours or days, right? It should be stable. Most of these times, these folks will come in with this chest pain. EKG looks great. We get labs. Labs look fine, right? But then we repeat that EKG, and if we see this, it's super concerning for Wetlands. These guys don't get a stress test in the hospital because if you stress them, they're going to VFib. It's pretty cool. You get to work a code, but it's not good for them. They need a heart cath. Oh man, this is my favorite video, and it won't play, Chief. Golly. Just more Wetlands. This is one that was in the ER a couple of weeks ago, and you can just see this. Sorry about the poor quality EKG, but interesting stuff. This was an older guy that kept falling at the nursing home. So we've done our exam, ABCs, but we're talking EKGs today. So this is the EKG. What do y'all think about that one? Too fast, too slow? Okay. Okay. I look for injury patterns. Y'all see anything concerning on the injury patterns? I don't see anything super scary. So look at intervals. PR. QRS looks reasonable. But what's our QT? Anybody see that? That's your T wave. That's your P wave. Whoa, that was crazy. Right? That's not good. Yeah, it's not good. Way too long, right? So a long QT interval can make people go into torsades and syncopes. So anybody that falls a lot, old people, unreliable historians, people on drugs that prolong the QT, always make sure you look closely at that. A lot of people out there on drugs that prolong the QT. Psych drugs do it. Any of your psychiatric medications, Zantac, Pepcid, Benadryl, all right, some of your antibiotics. So a lot of people own those medicines out there. But high-risk populations are our psych populations, our malnourished folks, the folks who drink a lot of alcohol because their MAG is low. This is very prone to having torsades. So this older guy was probably having runs and torsades that would self-correct, and that's why he was falling. So if he goes into torsades, what drug do you give him for torsades? MAG. How much you give him? And how fast? As fast as you can. There you go. Very good. Lots of drugs cause prolongation. We talked about those. This was a guy that we actually called on the monitor. He was a frequent flyer in the ER. Came in last winter. Is the date on here? I can't remember. It was 2 winters ago, but came in, said he wanted to hurt himself, needed a place to stay. It was cold. He was hungry. So I gave him a turkey sandwich, and the resident gave him some Zofran. And what does Zofran do? Prolongs the QT. Dude already had a long QT because he had some malnourishment. He was also on a lot of psych medicines. I was in a room doing a resuscitation. The nurse says, hey, guy in room 14 is coding. I just gave the guy in room 14 a turkey sandwich. So, but they were correct. He was coding. He got about 4 or 6 grams of MAG, defibrillated, and he got a overnight stay in the hospital. Asked too slow or okay. He says it's okay. 300, 150, 100, 75. So yeah, the rate's reasonable. I look injury patterns. 1 AVL and lateral. This should make me uncomfortable, right? If I finish it out, 2, 3 and AVF. This looks weird. That's a little concerning, right? V1 through V4, depression there. AVR and 1 are separate. I go back here, my P interval is good, but my QRS is wide. So I go look at V1, left bundle, right? So now I got to think Scarbosa criteria, right? So by Scarbosa, concordance is bad. So regular ST elevation, that is a big freaking lateral STEMI. This one is nothing inferior because this is discord, and discord is good. But what does our machine say? It says nothing about a STEMI, right? It says left bundle branch block. The machine's going to quit reading it right there. And had you just read this and looked at the patient, you would not have been concerned. But this should make you use profanity in your brain. They're having a big freaking STEMI and a left bundle. So we use Scarbosa's criteria. Scarbosa. He was a famous cardiologist years ago. It's funny. Well, this one. What is this? Too fast, too slow, or okay? And you can't say okay, even though it is okay, right? The rate's okay. But that should make you use profanity too, right? And pop an Imodium, because that's a scary looking rhythm. Yeah, so it's a pacemaker, and what's going on? So people think that when you get a pacemaker, you can't interpret anything. You actually can. You can use Scarbosa criteria to look to see if there's new infarct or injury. The other thing you got to think about is electrolytes can screw up pacemakers too, right? So pacers work and you get in a QRS complex, but that's freaking wide. So this could just be bad heart disease. It could also be an electrolyte problem because it's a wide QRS. And the rate's not going to be slow because they have a pacemaker. So this is actually hyperkalemia in somebody that's paced. And you treat that the same way. Albuterol, calcium, get them to the hospital, and we do dialysis or excretion methods. For that one. I say the ventricular rate's okay-ish. It's a little bit slow. But what are those dudes? Yeah, so that's a flutter that we've given medicines to slow the ventricular rate, but the atrial rate's still booking along. So this person does not need a calcium channel blocker or anything else. Anything that slows their heart rate down anymore is going to kill them because that's what generates the pulse, right? That's interesting looking EKG. So if you had that in your patient, they had complaints, they get IV access, they get the pads on, they get fluids, you do an appropriate history, you get an AccuCheck, the 12 lead, you move into the hospital. We're not going to treat atrial rhythms unless the ventricles follow that rhythm. This one's concerning. He's having some runs of Vtag. My first thought is there ischemia. I don't see any big ischemic changes. Then I'm going to think about long QT. Is it maybe that torsades? QT interval looks pretty good. It's half the R to R. But he gets pads on, and he has to figure out why he's having runs of Vtag. Potentially bad. Sorry about the quality of this EKG. I couldn't get it to scan well yesterday. What was that one? Too fast, too slow, or okay? Making you think now, aren't I? Yeah, good. So the rate's 300, 150. So it's less than 150, right? So technically, by definition, the rate's okay. I would argue that nothing's okay with that, though, right? So what does that look like? Near-death experience. I like that. Very good. Near death. That's right. Don't go to the light, right? So I would say it looks like Vtag, right? So it looks like Vtag, but it's slower than normal, right? Vtag should be greater than 150, all right? The machine's not going to do anything because it's a Y complex QRS. It's going to say a left bundle because that QRS is jacked up, right? And it's pointing down. So it's not going to interpret it for you, all right? So that's the complicated slow Vtag is what that is. You really don't have a lot of slow Vtags out there. If I see a Y complex tachy that rate is less than 150 or 140, I think of a couple things. First thing I think of is hyperkalemia in somebody that's dehydrated and dry. So is this hyperkalemia and they're tachycardic, not bradycardic? Other thing I think about is this Afib or a flutter in somebody with a really bad heart that has a Y complex QRS. They usually look sick as dirt. And then the third thing I'll think about is it Vtag, right? Most Vtags greater than 140 to 150. Risk factors would be they have a history of heart disease. This patient actually had a history of heart problems, had a history of dysrhythmias, was on amiodarone at home orally. And so they're in Vtag, but since they already had some amio on board, the rate was slower, which is weird. This is atypical. The medics were pretty astute, though. They recognized the patient's history. They were concerned for Vtag, called the orders sedated and synchronized cardioverted. Oh man, the next slide didn't show up. And patient actually did very well. But slow Vtag, I always think hyperkalemia with dehydration causing tachycardia, Afib flutter with aberrancy, or ventricular. If in doubt, synchronized cardioversion. That fixes most of it, except hyperkalemia. It kills hyperkalemia. Good, nobody smiled for that. That's great. All right, what about this one? Too fast, too slow, or okay? All right, injury patterns, 1, AVL, 5 and 6, 2, 3 AVF, V1 through V4. Look at AVR. Then I go back and look at my intervals at lead 2. QRS looks reasonable, so I don't have to look at V1. So, STEMI, no STEMI. What's the machine say? It never does. It doesn't matter. That's a trick question. When I say, what's the machine say? You say, who cares? Right? It's a cheer. Who cares? I would argue, if you look at this at first glance, you think maybe it's a left bundle, right? Because you got this pointing down, and you got elevation here and elevation here. So you're thinking, oh, it's a left bundle, not a big deal, right? In reality, though, it's not a left bundle because the QRS is not too wide. So this is a big septal MI that even the machine misses. So very important that you guys know how to understand and read these things. Now, if a guy's sitting there and he's got ankle pain since 1972 and that's his only complaint, probably not a STEMI. You're probably not doing the EKG. If you're sitting there diaphoretic, chest pain, weak, syncope, dizzy, don't feel good, I'm vomiting, you get this 12 lead, you see this and it's not a bundle branch block, that guy needs to see a cardiologist 30 minutes ago. This is another cool one. You're having runs of something, either atrial attack or something. I would never treat the tachycardia if you have periods of bradycardia, because if you treat the tachycardia, when they get bradycardic, they get more bradycardic. Then you get to pace them. Time is about up. I'm going to bypass this one, even though there's some cool videos there. Normal, abnormal. Very good. Thank you for recognizing that. Very abnormal, right? Remember, aspirin is one of the most important drugs we give these folks, right? Aspirin. We talk about these guys need oxygen for pre-oxygenation in case going to cardiac arrest. All our STEMIs get defib pads. In the hospital, we can either go in and give them a clot buster or open it up with a heart cath. Risk of death in the first couple hours post-STEMI is Vfib, Vtag arrest. That's why defibrillation is very important. The other risk is complete heart block and cardiogenic shock. So you got to be ready for either one of those. And that's what we learned a long time ago in paramedic school. But now we got to learn how to read 12 leads and get these guys to the appropriate hospital. This was an older guy with chest pain, not feeling well. Let y'all look at his EKG. I'd say the rate's okay. I'd say the intervals were fine. I'd say I don't see anything super scary as far as ST elevation, so it's not a STEMI. So I'm going to say no STEMI. All right. This is the EKG about 30 minutes later. Looks a little bit different. So that one, too fast, too slow, or okay. That one's like, yes, PR, no, do not PRT. Maybe CPR, but not PRT. Yeah. So this is very bad. So this is too slow. So I think of three things: drugs, electrolytes, or ischemia. I would argue that it's probably not drugs. He's been sitting in front of me for 30 minutes. It's probably not electrolytes. This is a big freaking MI. Dude is about to meet his maker. So remember, an EKG is static. It's just one point in time. If you have a patient that's concerning by history or story or exam, reprint that 12 lead. Gives you a lot of data. It gets you off the wall at the hospital. If you got a STEMI, you're not going to sit on the wall if you tell them, right? So I got 3 rules that I try to live by. I try not to kill people. That sounds funny, but we carry drugs that hurt people and do things. I try and help as much as I can. Then I want to go home with a clear conscience. And the way I do that is train. So there's a lot of responsibility in the world that you work in paramedicine, in pre-hospital care. You're doing things, doctor things out there. That's a great picture. Look at this. I don't know why a stethoscope's being carried there, but I love that photo. That's pretty cool. I'm a doctor, so that's a good one. Check, right? Yeah. And I understand that you work in an environment, to call you guys healthcare providers is like calling this person a laborer. I understand you work in a critical environment is dangerous. We're asking you to do things that we train our doctors for 10 years to do, and you get 2 years to do this, and then you get QI'd for it. But I appreciate what you do, but you got to train, man. It's healthcare is changing. Things we do changes all the time. You got to train to take care of sick people, just like you do for firefighting or anything else, because you are the last hope of these folks in the field. I think that's a Star Wars quote. You're my final hope or something. Wasn't that a Star Wars quote? Anybody a Star Wars guy? No. All right, great. Thanks for almost smiling. Questions, comments, or statements within reason? Chief, anything online? All right, just take 5 minutes and we'll come back.
So I'm Julie Brown, one of the EMS fellows at UAB. Going to switch gears and talk about environmental emergencies, so more like hyperthermia, hypothermia. So obviously in Alabama, in the summer, it gets really hot. You might have patients with heat strokes. Very rarely does it look like this in Alabama with the snow, but it can happen and people probably aren't ready for it. All right, so these are the things we're going to talk about, more kind of cold-related illnesses and then heat-related illnesses. All right, so we're going to start with a case. So you have a 40-year-old, no medical problems. His friends called because he's really confused. They just found him in the woods. They were skiing somewhere in Tennessee, and they lost him a couple hours ago. When you get to him, his heart rate's 72, blood pressure is 90/65, breathing 11 times a minute, and his O2 sat's fine. His eyes are open, but he's confused, not really answering your questions, but moving all of his extremities, but he seems sort of clumsy, something you wouldn't expect for a 40-year-old. So is there anything else you would want to know for this guy?
Where in Tennessee is that mountain? I want to go.
Unclear.
Okay.
Maybe it's in, pretend like it's in Colorado. How about that? Oh, I'm like, I don't know, I don't ski. I'm just making it up. Okay. So other things that we can think about is like, what's his temperature? Obviously hard to get a temperature, especially a good core temperature in the field, but something else to think about. And then we'll go through talking about hypothermia cases, and then we can decide what we want to do with them. All right, so below 82 degrees, a human being can really not produce enough heat to maintain their body temperature without like having clothing on or having a heat source. So they really require protection from the cold. And from 1999 to 2011, an average of 1,300 people died annually in the US from hypothermia. So obviously these problems are really common, especially I would say in Alabama, especially in the Birmingham region. There's a lot of homeless people that don't have a home, don't have anywhere to go, they don't have any shelter, so they're probably not ready for the cold when it happens. So hypothermia is defined as a core body temperature below 95. There's really two main types. There's primary hypothermia, which is more like wilderness, kind of environmental. You were out in the cold and your body can't produce enough heat to keep you warm. So that would be like the lost hiker that's in the snow. Versus secondary hypothermia, which is a more urban hypothermia, which is patients that are exposed to the cold, but then they have all these other medical problems. It wasn't that they were just stuck in the snow and they weren't ready for it. It's that they have high blood pressure, diabetes, they're on a beta blocker, they have heart problems, they're an alcoholic, maybe they only have somewhere to stay on the weekend. So that's more urban hypothermia. So think of like a old lady who's had a history of a stroke, who can't get up and go get a blanket, who can't get up and turn her heat on, things like that. So really your body temperature reflects the balance between heat production and heat loss. So you take in calories, you metabolize those calories, and you make heat. But then there's 4 ways for you to lose heat. So radiation, evaporation, which would be like sweat and sensible losses, conduction, which is like direct transfer of heat from like your body to a cooler object. And the greater the kind of amount of uninsulated body that you have, the greater loss of heat you'll have. And then convection is the direct transfer of heat to convective currents of air, water. So essentially your body is creating a little microenvironment around you and heating up that environment. And if you're around air or water, moving air, wind, water, your body is constantly trying to reheat that little microenvironment. So we talked about the ways that the body loses heat. And then there's 2 mechanisms really to defend against heat loss. Obviously, the first one would be behavioral: go into a house, turn your heat on, or put on more clothes. And then your body can produce heat by shivering, so muscular activity. So in order to prevent wilderness hypothermia, you really have to recognize that, hey, it's too cold for me out here. I need to alter my plans. I need to wear more like better clothing, or I need to, take in more calories so that I can produce more heat. But really preventing urbathermia is a lot more complex. It's a lot harder to have the 85-year-old be able to turn the heat on who can't walk. So that's a lot more complicated. So we talked about this. So your core body temperature below 95 is the definition of hypothermia. Then we can break it down into mild, moderate, and severe. Mild would be like 90 to 95, moderate 82 to 90, and then severe would be less than 82 degrees. But measuring a true core body temperature in the hospital is hard. A lot of times we don't have temp sensing Foleys or a good accurate thermometer. So obviously it's going to be even harder in the pre-hospital setting. So we can think about it more of the stages based on their clinical presentation. So essentially think of hypothermia as a patient that is exposed to too much cold stress that they're not having enough, they don't have the ability to produce enough heat to keep up with that. And then you can look at their clinical presentation to kind of determine what stage they're in. So these are kind of the stages with the symptoms that they'll have. So with mild hypothermia, the patient might be shivering, kind of going to a lower temperature. They might start losing their fine motor skills, kind of being able to pick up objects versus their gross motor skills. So they might not be able to walk by the end of it. And then they might start getting confused. So these people initially usually are able to self-rewarm themselves. So they know that, hey, I need to put on more clothes. Hey, I need to get out of the cold. Versus moderate hypothermia, these people really aren't shivering anymore. Their heart is more vulnerable to cardiac dysrhythmias, especially Afib. And these patients may go from confused to unconscious. So obviously, if they're unconscious, they're not able to get out of the cold. Versus severe hypothermia, so less than 82 degrees, these people can be rigid. They might look like they're in cardiac arrest. They may not have vital signs. And their heart is very vulnerable to dysrhythmia. So they might go into Vfib if you just pick them up and start moving them to a rescue versus just going into Vfib automatically. And then they might present in a coma. So treatment for hypothermia really depends on whether or not the patient is able to get up and try to self-rewarm themselves. So if somebody is in mild hypothermia, so they still have some metabolism that can produce heat, really eliminating that cold stress might be enough for them. So getting them out of the cold, putting them in a heated rescue, giving them extra blankets, removing any wet clothes that they have on is probably going to be enough. Versus patients with moderate hypothermia, they might be confused and not able to do what you're asking. So these people might need more active intervention. So you might need heated blankets if you have the ability to get those, or heat packs put in like the axilla, the groin, the neck, or if you have access to heated IV fluids. Things that are not recommended are putting patients in warm water because that actually increases their mortality. And then patients with severe hypothermia, I think these are, think of the homeless patient that lives in a tent who somehow somebody found them and called 911 and they're just a sheet of ice, like just completely solid. So you could think of that person, or you could think of somebody who was just out in the cold and maybe we found them a couple hours later. So we say that nobody is dead until they're warm and dead, but there are people who are dead and they're not going to be able to be resuscitated. So if that person is completely frozen, there's air in the airway, there's ice in the airway, ice in the nose, their chest is so rigid that you can't do chest compressions, you're not going to resuscitate that person. Like, you can withhold resuscitation. But otherwise, if you think that they have a good chance of survival, try all reworming things that you can do. You can attempt defibrillation. It's probably not going to work. So kind of current recommendations by the AHA is that you can attempt up to 3 times for defibrillation, but they said it's probably not going to work. And then you probably don't need to give people who have a temperature less than 86, like epi or amiodarone for refractory Vfib, because it's not going to work at that temperature. And when you start raising their temperature, those medications can accumulate to toxic levels. So patients with hypothermia, generally you're going to transport to the hospital, especially if they have urban hypothermia. So it's like the older lady who can't warm herself up. She probably needs to go to the hospital. If it's a patient who is just mild hypothermia and you're able to get their wet clothes off, put new dry clothes on, they're not confused, their vitals are fine, they probably don't need to go to the hospital. Versus a patient with moderate hypothermia probably needs to go. If they're confused, if they don't have the ability to self-rewarm, they probably need to go. Unless for some reason you're in Colorado and there's an expedition team that has provisions to self-rewarm or to rewarm actively. So they have heated blankets, they have heated IV fluids, and the patient comes back to normal vital signs, normal mentation, and everybody in the group is in agreement that they don't want to go, then maybe you don't need a transport. And obviously patients with severe hypothermia who have signs of life need to be transported to a hospital. So back to this case. So there's a 40-year-old who was skiing somewhere who's hypothermic. So say you had a thermometer, you're able to get a temp of 91, and he's confused. So if he's confused, kind of clumsy, he's probably doesn't have great fine motor skills. So he's probably suffering from mild, kind of going into moderate hypothermia. So things you could do for him: remove wet clothes, put him into a rescue with heat, drop him in warm blankets, and then if you have IV fluids that are heated, you could start those. Any questions about that? And then that would be kind of in like difference to this case with the 85-year-old who can't move her right side, who's trach and peg dependent, who the nursing home called because she's not acting right. Oh, and somebody left her window open in her room last night. So she's hypothermic, she's tachycardic, she's hypotensive, a little hypoxic. So people like this, she's hypothermic, but she's probably septic too, right? So we can't say that she's not based on those vital signs. So obviously I would transport her to the hospital. In the hospital, we'd probably give her antibiotics, treat her like she's septic, warm her up until we know she's not. That's what I just talked about. Okay, so moving on from just hypothermia. So now we're going to talk about trench foot, which has some great pictures. So trench foot or immersion foot is the same thing. So it's a non-freezing cold injury. So it's a patient who is out in the street who, when it's cold but not freezing, so like this morning when it was 43 degrees out, or if it's wet and non-freezing, people can get these injuries. So usually it occurs from water exposure. If it's cold out and you have vasoconstriction of your extremities, so your fingers, your toes, because you're vasoconstricting in your extremities to save that blood for the organs that need it. Or if patients have too tight of footwear, too tight of socks, or if they're not moving around a lot. And then that prolonged vasoconstriction can lead to damage, and then that causes tissue damage. So things that you can do for trench foot: remove any wet garments, elevate their feet. You don't need to rewarm the feet or the tissues, but if their core body temperature is low, you would rewarm their core body temperature. So you don't have to immerse the feet because it's not a frozen injury. Trench foot's not frozen. So this is an example of trench foot. So this is kind of too much into the weeds of what we would need to know, but there are really 3 phases of progression for trench foot. So this is like the pre-treatment phase. This is the phase that you would see more a pre-hospital, hospital setting, where the patient has been out in the cold, wet environment that's not freezing, but their feet look like this. So they usually have anesthesia, so their feet feel numb. They're kind of a blanched, yellowish white. They might be edematous like this. But it really just looks like your feet have been exposed to the water for far too long. And then once they start getting treatment, their feet start warming up. They can get more hot, red, swollen, painful. And then if they have trench foot at some point and then they recover from that, kind of long term, they can have persistent cold sensitivity and feel like their limbs are cold. So that might be another patient that you see of somebody who used to have trench foot, but now they have a house and they aren't exposed to the cold anymore, but their feet are always cold. So things that you can do to prevent trench foot, obviously can be hard for somebody who's homeless, but wearing clean, dry socks, taking breaks from the cold, wet environment, and keeping the feet dry. Now we'll talk about frostbite. So trench foot was a non-freezing injury. Frostbite is freezing. So frostbite is a combination of freezing temperatures and then your body not producing enough the heat to prevent that tissue from freezing. So you can get frost nip, which is when you get ice crystal formation, but you don't have tissue damage. And that would precede frostbite, which is ice crystal formation in the tissues, but you actually have tissue damage. Tissue freezing doesn't always result in permanent damage. So if somebody has frostbite, there's a potential that they could recover from it because the cells that have the ice crystals are metabolically inactive. And so they're not dead, but they're not doing much, right? And so when you rewarm those tissues that weren't getting any blood, those cells weren't active, you can get more damage because you can get thrombosis from the cells that weren't working. That makes sense. Okay. That was a little in the weeds, but things that you're going to see, because I know I've seen a lot of patients brought into the ER with frostbite, especially in the winter in Alabama with our homeless population. But early on, the patients will have a cold sensation. They might have pain. Their feet or hands might be pale. And then once freezing occurs, they're just going to feel numb. They won't have as much pain. And then when the tissues start freezing, then they might start becoming purple and more firm. So this is the kind of grading system we use for frostbite. So first degree frostbite is really just kind of looks red, angry, but there's no tissue loss. So it's like that. But then when you start getting blisters, we think it's second degree. So first degree just looks red and angry, and then second degree, you start having blisters. And then third degree, you start having more hemorrhagic blisters. So these look like something that you would probably want to open up and try to get that blood out. But you're actually not supposed to with third degree. You're supposed to leave those blisters intact. And then fourth degree frostbite is more involving the subcuticular tissues, so more bony involvement. So you might see their toes and you can actually see the bones. Yeah.
Hey, so I had a question. So what causes the blisters? Is it vasoconstriction, like kind of the same way as trench foot mechanism?
I think so, but then you also have that underlying ice crystal formation with tissue damage. So I think it's a combination of all of the things. I don't think there's just one thing that causes the blisters. I think it's like with first degree, it's one level of tissue, and then as you kind of get down an ice crystal formation in the deeper tissues, then you start forming the blisters. So treatment for frostbite. So if a patient has frostbite, if you're working in Colorado and we're in the mountains kind of closer to Alabama and somebody looks like they have frostbite, if for some reason if you're going to be able to take them out into the rescue and take them straight to the hospital, then you can try to rewarm that, whatever frozen part it is. But you will really want to avoid thawing and then refreezing. So if a patient's like in the middle of the woods and you're going to have to extricate, you're not going to warm those tissues where they are initially because there's a potential that it could refreeze. That makes sense? And then for frostbite, you will treat any core hypothermia. So make sure their core temperature is like at least 93 degrees. And then you can immerse that frozen part in warm circulating water. So 99 to 108 degrees. So if you had a long transport time and you know that they're not going to have time to refreeze, then you can try to start rewarming their tissues. These patients are going to have a lot of pain. They're probably going to need narcotics, fentanyl, ketamine, whatever you have to treat pain, and then just kind of wrap up the areas just to protect it. Preventing hypothermia is the same thing as, or preventing frostbite, similar to preventing hypothermia, is knowing whenever you're getting too cold and having the ability to rewarm yourself. Okay. And now, well, moving on to cold water immersion. So cold water immersion is when a patient is below, is in the water, but has their head above water, so they're not drowning. So the temperature of the water is less than 77 degrees, but their head is still above water, but they're not able to maintain their body temperature in this degree of water. So with cold immersion, patients will initially have a cold shock response. So for about 1 minute, the patient will start hyperventilating. They might have a gas reflex. And if they aren't able to control their breathing, then they're probably going to lose consciousness from hyperventilation and drown. So that lasts for about 1 minute. And then if they survive that, if they're able to control their breathing, they have about 10 more minutes left of useful activity. So they can try to swim to shore, try to call for help if they see someone else that can rescue them. But typically this will, if they don't have a flotation device, these people are usually gonna drown because they're gonna lose consciousness and not be able to move their extremities in order to swim. And then about after 30 to 60 minutes, they'll face a significant risk of hypothermia. So think of it as like the 1-10-1 rule. So you have 1 minute to control your breathing, then you have 10 more minutes of purposeful activity to either increase your chances of survival, swim to shore, call for help, and then you'll have 1 hour until you become unconscious and you might suffer from hypothermia. Obviously, think of safety first. If a patient is underwater in the cold, then there's a risk that you could also end up in the water. So make sure you're wearing a personal flotation device, that you're wearing protective insulating clothing. And treatment for these people are obviously start with your ABCs. If they need an airway, get an airway, I-gel, intubation. Make sure that they're breathing appropriately. They might be bradycardic, hypotensive, so you can treat that accordingly, and then start rewarming them. So kind of finishing up the cold injuries. So obviously cold injuries are common, especially when you're not prepared for them. So we just need to be familiar with the presentation of these complaints and then anything that we can do to start treating them. Okay. I think this is the more fun stuff, the hyperthermia cases. So you have a 23-year-old, no medical problem, used after he ran a marathon. He's hyperthermic to 105, he's tachycardic to 130, blood pressure and all his other vital signs are fine. He's awake, looking around, but he's warm, he's not operatic or steady. His extremities, but he's not really able to answer a lot of your questions. So we'll talk about what we could do for him and what his diagnosis would most likely be. Okay, so heat-related illnesses, an average of 688 people die annually, and between 1999 and 2003, an estimated of almost 3,500 people died secondary to heat injury, and males accounted for most of those deaths. And the majority of those deaths were also between the ages of 15 to 64 years old. Whenever patients have a heat-related illness, their minute ventilation, their heart rate, their cardiac output are all going to go up. And you have really kind of the pathophysiology that we're not going to go, there's a lot of detail with this, but it causes a severe inflammatory response, kind of denaturation of proteins, and a lot of problems that cause cell death. And then you have to think that if a patient is hyperthermic, but also on medications like vasoconstrictors or beta blockers, that can also prevent them from getting rid of heat. So if they're on a beta blocker, they're probably having less blood flow to their extremities or to their skin, so they're not going to be able to dissipate as much of the heat. All right, So these are the heat-related illnesses we're going to talk about: heat edema, syncope, tetany, and then cramps, exhaustion, and stroke. So heat edema is really one of the mildest forms of heat illness. It's really just kind of vasodilation, pooling of interstitial fluid into the extremities. These people have a normal core body temperature, and it most commonly happens in the elderly and anybody who's not used to the heat. So somebody who is used to living in Minnesota or kind of Northeast who comes to Alabama to see their family, they might get heat edema. There's really nothing that you have to do for these people except move them to a cooler environment, get them into their house where they can be cooled. They don't need any diuretics. The edema will get better with cooling them off. Versus heat syncope, these are patients that are going to have syncope, dizziness, orthostatic hypotension. I know we see this very commonly in Alabama in the summer, especially people in church who are sitting down for a long period of time and then they stand up to start singing. They might syncopize if the church is really hot, if it's hot outside. When you're at a football game, people can get heat syncope. Talladega, people can get heat syncope, or even like bodybuilders who are laying down to do like bench presses and then they stand up, they can also syncopize. So these people, their core body temperature is unaffected, but again, it's secondary to venous pooling and that peripheral vasodilation. So these people, move them to a cooler environment. If they're able to rehydrate orally, let them do that. If they're hypotensive, you can give them IV fluids and then they'll probably feel better.
Hey, Doc, so is heat syncope usually not related with exertion?
Yes, it can be related to exertion. So think of like the bench presser who's laying down doing bench presses and then he stands up all of a sudden, all that blood is going to go to the periphery and then he's probably going to pass out. But it can also be the person who's sitting in the hot sun at Talladega and then stands up all of a sudden and starts walking up the stairs. Those people weren't exerting themselves and now they are, and they might pass out too. I saw a lot of those people at Talladega, a lot of people that passed out. Okay, and then heat tetany is just a spontaneous muscle spasm that happens when people are in the heat. So if somebody is out in the heat, they start hyperventilating, they can get a respiratory alkalosis, meaning their CO2 is going down. And with the CO2 going down, they can get just weird muscle spasms. So they can get these two signs, the Trousseau sign, which is the one on the right, and then the, how do you say that one, Dr. Ferguson? Chovastic. They're usually, yeah. So these are normally signs or things that you see with problems with your calcium, but you can also see it with heat tetany. But these patients' core body temperatures are going to be normal, maybe slightly elevated, but all you have to do is remove them from their environment and they'll get better. So they'll stop hyperventilating, their CO2 will become normal, and then this tetany will go away. But this is normally something you think about with calcium, but you can also see it with patients that are out in the heat. All right, so heat cramps is the real mildest form. So you think of heat-related illnesses, think of heat cramps, heat exhaustion, heat stroke. So heat cramps is going to be the mildest of those three. It's really just cramping in your skeletal muscle after exerting yourself. And it's usually due to hyponatremia. So patients that are losing a lot of fluids in their sweat and then they're going to drink water, which is hypotonic. So their core body temperature may be slightly elevated, but it can also be normal. So these people, you just orally rehydrate. So things like Powerade, Gatorade, things that are going to have some sodium in it. And they usually get better. Versus heat exhaustion, their core body temperature is going to be elevated and they might have more systemic signs. They might be tachycardic, their skin might be flushed, they might have nausea, vomiting, they might be complaining of a headache, but they're going to have a normal mental status. So they're not going to really have as many CNS complaints. So things you can do for them, start cooling them, taking off any of their unneeded clothes, You can put cold water over them. So the easiest thing to do is to kind of spray them with water, pour water over them, and then to put a fan on them to evaporate some of that heat, and then rehydrate them. Versus heat stroke is going to be the most serious of the heat-related illnesses, where the patient's going to have a core body temperature usually greater than 104, and then central nervous system dysfunction. So these people might be ataxic, confused, they might have seizures, or they might present in a coma. Later on in their illness, they might develop hepatic failure, pulmonary edema, renal failure. And this heat stroke actually carries up to a 10% mortality risk. And the people that usually are going to have that higher mortality risk usually are presenting later in their illness. They might not initiate treatment early enough, or they might just be more severe on presentation. So there's two forms of heat stroke, sort of similar to the two forms of hypothermia, but there's exertional, where it's just the young, healthy person that's running a marathon that they're generating too much heat. So it's more of an internal heat stress, heat generation, versus the classic form, which is more commonly in the elderly, more debilitated patients, that it's more of an external problem. So the patient that isn't really, you're not doing anything to produce as much heat, it's more the heat acting on them. So it's more of an external. Treatment, obviously start cooling the patient, move them to a rescue with air conditioning, take off any excess clothing, pour water, cold water over them, cool ice packs in the neck, axilla, the groin, and then try to rehydrate them with Gatorade, Powerade, whatever you can get. If they're not mentating normally, if they're confused, then you're probably going to want to use IV fluids. And if they present with a seizure with heat stroke, then obviously treat the seizure with benzos, and then you can also use IV fluids. So cooling patients in the pre-hospital setting, there are a lot of commercial cooling units that are out there. Ice water immersion is out there, but it's not really practical. It's something that you're going to have on the rescue. It has a limited shelf life, very costly. If you're putting somebody in ice water, it's difficult to get to their airway. If they have an IV, it's going to be difficult to get to their IV. So things that are more practical are just moving them to a cooler environment, pouring cold water over them. If you have the ability to get to a fan, to put that fan to cool that water that you poured on them, and then using ice packs. Okay, so this was the case. You had a 23-year-old who's confused after running a marathon, who his skin is warm and dry and his temperature is 105. So he's confused. His temperature is greater than 104, so he probably has heat stroke. So things that we could do for him: remove any warm clothing, move him to a cool environment, pour cold water over him, and then try to rehydrate him. And then kind of in conclusion, there's a lot of heat-related illnesses that range from very mild to very serious with heat stroke. So we just need to know about these conditions and the things that we can do to treat them in the field before they get to the hospital. That's it.
So I had one question. So heat stroke can be dangerous for firefighters
Yes.
because all of their body surface is covered with gear
Yes.
during periods of high exertion and a high ambient temperature.
Yeah.
So are there any proven steps to prevent heat injury prior to being in that environment? In other words, are there any steps that firefighters can take other than just general good fitness and hydration?
Yeah, just being generally healthy, I think, would be the best thing, having good cardiac function. But I don't know if there's any like training of your body that you can do. Yeah.
Anybody online, you can type questions if you have anything for Dr. Brown or Dr. Ferguson. One thing that was texted to me was you were talking earlier in hypothermia about cardiac arrest care and probably withholding cardiac drugs, do chest compressions if they're not frozen.
Mhm.
And defibrillation is what the discussion has been about. Is it normal? Because my reply to that is I would think that would be highly unlikely for a patient who has no signs of life and is frozen to be in VFib. I would think that they would be in a systole, but I don't really know the stats on that.
I think if somebody's hypothermic from a submersion injury and they're told when you get them sitting there in VFib and you throw them Lucas and you work them slow, not slowly, but appropriately give them a hospital, there's a chance that person will get that right. Lucas does a great job of cardiac output.
I've seen the recommendations before to not defibrillate if the patient's severely hypothermic. I just wonder what the occurrence of that is, if that's even something to worry about. Because it seems to me that if they're fibrillating, that whether they're frozen or not, it would be appropriate to attempt defibrillation.
I think that's reasonable. I'll still stick the Lucas on them.
Yeah.
Cut down the heavy doses. I'm not sure there's a lot of good hard data on there. I just can't do a good trial with it.
Yeah. I say what I read on Up to Date and then the AHA says that you can attempt defibrillation up to 3 times, but it's likely not going to do anything whenever they're severely hypothermic. You could try to rewarm them and then defibrillate them, but if you wanted to try, it's probably not going to harm them.
Okay. Fair enough. Dr. Ferg, you got anything?
Just a few things. Other things to think about for people who have heat exposure and illness. It's very common for those guys to get rhabdomyolysis, where you kind of get a muscle breakdown and it's a protein breakdown that kind of tears up the kidneys. So those guys, even when they get better and you don't transport, you need to recommend they be evaluated to make sure that nothing long term. We don't have any big kidney injuries with that, especially if the dark urine. The other thing I've seen in the fall season around here, when you have these kids that are practicing for football in the gyms and working out, having issues, they'll get dehydrated, hypotensive, and go into what looks like SVT. But when you touch them, like you could cook an egg on their forehead, they're so hot. And I've seen people give adenosine for that. So if adenosine doesn't break that SVT, it goes right back in. Think of the underlying reasons, and it could be the hyperthermia for those folks. I also think about your risk factors. So things that make you more prone to having a bad outcome, whether you're too cold or too hot, will be like age. The more mature in life we get, more risk, just like the young kids, and then pre-existing illnesses. And then the other thing to think about is drugs and alcohol really impact that. I mean, we've seen people at Dega who are hypothermic, and it's not really that cold, but they're, butt naked, drunk in the camper or on top of the camper all night, and you have issues with that. I guess I could say butt naked on, I don't know.
No, you can say buck naked, but not butt naked.
Buck, that's what I said, buck naked.
That's what I thought you said.
Okay, yes, sir. Oh, help me. Couple things. Don't forget, next week is the Coast Conference. If you can get down that way, do it. SMEC is Tuesday. The town hall, I think, is at 1, and then the meeting's at 2. I'd recommend going if you're interested in that. EMS Challenge, we're going to be at Brams December 8th. And then we're at the Alabama Association of Rescue Squads on November 12th, 13th, I believe. It's down in Foley. We're planning next year's schedule. We should have that calendar out by January. Going to try to hit some place we went last year. If you have a desire for us to come to your location, reach out like in the next week or two. As we get this kind of tied down, we're happy to come out that way.
So we just had somebody start a discussion about how does targeted temperature management and hypothermic cardiac arrest intertwine, or how are they related, if at all? How does target temperature management work? Because there's clearly data that supports that it preserves neurological function.
Right. So I would say for that, come in January 16th Dr. Kurt, who works with our hypothermia team, is going to explain that in great detail and talk about that. Because one of the things we're trying to push at UAB right now is a resuscitation center. So out of hospital cardiac arrest patient that we get ROSC on, it's great to get them to a place they can do heart casts, do ECMO, and hypothermia, or targeted temperature management, whatever you want to call it. And he's very into this. He'll be here January 16th and talk about that.
Okay, fair enough.